Okay, so we are going to treat the plantar surface of the foot. This is a protocol that would be used for a patient who had a plantar fasciitis. We're going to also include the gastrocsoleus in this group to improve flexibility in that muscle group and improve ankle dorsiflexion, which is going to be an important aspect of managing a patient who has plantar fasciitis. The usual site of irritation is where the plantar fascia inserts into the medial aspect of the calcaneus. This is a very tough fibrous band that crosses the entire bottom of the foot, inserts into, all of the metatarsal heads and metatarsal phalangeal joint area. So we want to stimulate circulation into this region and perhaps even stimulate an inflammatory response. Very often this condition is degenerative. It starts out as an inflammatory condition and then over time it becomes degenerative in nature, and the inflammatory healing process kind of gets to a standstill, and we want to kind of break that cycle and start things over again as part of the management of treating this. Plantar fasciitis generally respond very well to a combination of manipulation, instrument-assisted connective tissue techniques like ConnecTX, which is what we're using now, utilizing the ConnecTX instrument, and rehabilitative interventions like restoring dorsiflexion, increasing the pliability and flexibility of the gastrocsoleus group, looking for overpronation syndrome during gait. That can be a contributing factor. Things like obesity can also contribute to this. Prior injuries to the lower extremity, especially the foot ankle inversion sprains, can be a contributing factor as well. So you want to ultimately look at the entire kinetic chain. So for example, in a patient who has chronic ankle sprains, there could be some gluteus medius inhibition, and you might have to include strengthening exercises for that, or perhaps stretching out the adductors. I'm just throwing out some examples of looking at the kinetic chain. But right now we're going to concentrate on the actual instrument-assisted connective tissue manipulation, mobilization of the plantar fascia as part of the management, overall management of this condition. So we have emollient on the bottom of the foot, and I just using a single handhold and covering the entire plantar surface of the foot. This has to be done to patient tolerance. Some patients, when they're very acute, will not tolerate a lot of pressure in this region, so you'll have to use your discretion and your experience to kind of tell you how much you can engage the tissue. It also depends on when you're going to treat them again. So if you're going to treat them in a couple of days, you're going to have to go a little bit easier than if you're going to treat them in a week, right? They will have time to recover from the treatment. So I generally don't go directly to the spot, right? I kind of just work the entire plantar fascia. When the toes are dorsiflex, that's when the fascia tautens, right? So it allows me to get a good stretch, and you can feel some of that crunchiness in there as you come across. And I'm just working my way from the toes back towards the heel. And I want to come across the tissues as well. I'm holding the toes in a bit of dorsiflexion to put a stretch on that plantar fascia. Going to pay a little closer attention to the attachments at the big toe and just work that with it under a bit of a stretch. Going to change over to a pencil grip. Doing okay?
Yeah.
All right. Now, in a symptomatic patient, you might not be able to do all this, so you kind of get what you can and just do it in shorter intervals. I'm going to come across the tissues here as well. I can see I can even get underneath. If I slacken a little bit, I can get underneath that medial border right there. With the toes plantar flexed passively, I can really kind of stretch it out here a bit. And now I'm working my way backwards towards the calcaneus. Using some C curls, if you will, just kind of coming across, making a shallow C across the tissues, working my way back towards the heel. I'm going to switch over to my convex edge and get a little bit more aggressive here. If it's more comfortable, this can also be done with the leg in a straight position, the table all the way up. I have it elevated like this so the camera can see it. And that's very kind of crunchy right there. So I'm just kind of ironing it out with the ConnecTX instrument. And now I'm working my way right up to that medial calcaneal attachment. This is often the most sensitive area. And I'm just concentrating right in that attachment. Sometimes patients will have heel spurs here, but that's more of a symptom of the chronic state of this condition, not the reason that it's ongoing. It's again usually a degenerative, stalled, inflammatory condition. Doing okay?
Yep.
Okay. And I will work my way out over the heel as well. And I'm going to work the Achilles tendon on the outside. The camera can't see this very well, but it'll see it better when I'm doing the inside. Working that Achilles tendon. This is improving dorsiflexion as I'm doing this. Least of the soleus because the knee's bent. We'll do this also with the knee straight to pick up more of the gastroc. And before I move down and treat the gastroc soleus, I'm going to, usually this is like the finale, I'll kind of take my dagger grip right here and just really get into that medial calcaneal attachment. You okay? And I'll mix up my directions. A little slack, a little stretch. You could switch hands here, come from different directions, but I'm going to keep it like this so that the camera can see it better. Doing okay? And if the patient will tolerate it, I could even try it out with my smaller edge. So just kind of come in with my small convex edge. Perhaps not go as deep because it's more concentrated, but it gets me into a smaller area. You okay?
Yeah.
All right. I can tell that's just at the lateral limit of tolerance right there. Okay. And you know, treatment probably typically wouldn't last as long as I was just demoing it, kind of just wanted to show the maneuver to the camera. But patient tolerance always rules. You're always better off a little less than too much in the beginning, especially if you're not sure how they'll react.